Implantable Cardioverter Defibrillator, or ICD, is an electronic device that continuously monitors the heart's rhythm and delivers therapy when it detects a dangerous arrhythmia. It is most often used for patients at risk of sudden cardiac death, especially from ventricular tachycardia or ventricular fibrillation. Patients may receive an ICD for one of two main reasons. Some need it for secondary prevention, meaning they have already survived sudden cardiac death, usually caused by ventricular fibrillation, or they have had symptomatic ventricular tachycardia not related to a reversible cause. Others qualify for primary prevention, which applies to patients with coronary artery disease who are at least 40 days post-myocardial infarction and have an ejection fraction of 35% or less. It also applies to those with nonischemic dilated cardiomyopathy lasting at least 9 months and New York Heart Association Class II or III heart failure. While waiting for a permanent ICD, some patients may wear a defibrillator vest. This wearable device monitors the heart around the clock and can deliver a shock within a minute if a dangerous rhythm occurs. The vest vibrates and alarms before delivering the shock, and although it can be life-saving, it must be worn all the time except while bathing, with the battery changed daily. The ICD itself is about the size of a pack of chewing gum. It consists of a generator implanted in the chest wall and at least one right ventricular lead placed transvenously. Implantation and recovery are very similar to a pacemaker procedure, and most patients are discharged within a day. The device is programmed to respond when the heart rate exceeds a certain level or when changes are detected in the isoelectric line. Once the ICD identifies a dangerous rhythm, it confirms the arrhythmia, charges, and then delivers therapy. Some models even allow patients to activate atrial therapies on their own. Battery life averages 9 years, and device clinics routinely check stored electrocardiograms and shock logs. ICDs deliver therapy in several ways. One option is antitachycardia pacing, where the device sends a rapid series of impulses to interrupt a reentry circuit and stop tachycardia. Some devices can provide low-energy synchronized cardioversion, while all are capable of delivering high-energy defibrillation to reset chaotic electrical activity. Many ICDs also function as pacemakers, usually programmed in VVI mode, to prevent bradycardia after therapy is delivered. A newer alternative is the subcutaneous ICD, or S-ICD, which avoids vascular access and is most appropriate for patients who do not require pacing or cardiac resynchronization therapy. As with pacemakers, ICDs have a coding system. The first letter identifies which chamber is shocked, the second indicates the chamber that can be antitachycardia paced, the third shows whether the device uses electrograms or hemodynamics to detect tachycardia, and the final letter indicates the chamber that has anti-bradycardia pacing. Complications are similar to those of pacemakers and include infection, hematoma, pneumothorax, lead dislodgement, or premature battery depletion. The most common long-term issue is inappropriate shocks, which often result from oversensing or from atrial arrhythmias that conduct rapidly to the ventricles. These problems usually require device reprogramming. Nursing care after implantation focuses on monitoring the patient's heart rate and rhythm with electrocardiography. Nurses compare the ECG with device settings to confirm function and evaluate cardiac output and hemodynamic stability. If the patient develops ventricular tachycardia or ventricular fibrillation, the ECG should be reviewed to document the timing of the arrhythmia and the ICD's response. The incision site must also be observed closely for bleeding, hematoma, or infection, and any signs of swelling, drainage, warmth, or persistent pain should be reported right away. A chest X-ray is generally performed before discharge to confirm lead placement and to rule out pneumothorax. Medications can influence how the device works, particularly by changing pacing thresholds. Antiarrhythmics, beta blockers, and diuretics tend to raise the threshold, while corticosteroids can lower it. Nurses need to understand these effects and recognize when device function may be impacted. Equally important is the psychosocial side of ICD care. Many patients feel anxious, depressed, or fearful after implantation. They may struggle with lifestyle changes or feel helpless because of the unpredictability of shocks. These emotions are normal, but if patients show signs of isolation, irritability, or prolonged depression, nurses should step in to help. Encouraging open discussion with family and the healthcare team, setting realistic goals, and connecting patients with support groups can make a big difference. Stress reduction strategies like relaxation or deep breathing exercises may also help. Preventing infection is another critical nursing responsibility. Dressings should be changed as needed, and the site must be inspected daily for redness, swelling, or unusual drainage. Any fever or elevated white blood cell count must be reported immediately. When patients transition home, education becomes the priority. Because the hospital stay is short, anxiety may interfere with learning, so caregivers should be included and provided with written materials. Teaching covers the importance of follow-up monitoring, medication adherence, site care, and recognizing safe versus unsafe activities. Patients are reminded to restrict arm movement until the incision heals, avoid raising the arm above the head for 2 weeks, and refrain from heavy lifting. While most daily activities can resume within 2 to 3 weeks, contact sports should be avoided. Electromagnetic interference must be discussed as well. Large magnetic fields from MRI machines, arc welding, or industrial motors can deactivate the device. At airport security, patients should present identification and request a hand search instead of going through the gate. Cell phones should be carried on the side opposite the device, while microwaves and most household appliances are safe. Patients are instructed to keep a log of ICD discharges, to call emergency services if they feel dizzy or if shocks occur unexpectedly, and to bring the log to follow-up appointments so providers can adjust therapy as needed. Family members are encouraged to take CPR training and to be aware that they may feel a mild shock if in contact with the patient during an ICD discharge, though it will not harm them. Patients should wear medical alert identification with their device and provider information and be connected with community or online support resources. In summary, the ICD is a powerful tool in preventing sudden cardiac death, but it comes with challenges that extend beyond the technology. Nursing care, patient education, infection prevention, and emotional support are just as critical as the device itself. With the right support, patients can adapt to life with an ICD and continue to live fully and safely.